Welcome back, y'all, to the Nourishing Women podcast, your go-to podcast to get your period back and get pregnant. I'm your host, Victoria Myers, period recovery specialist, fertility dietitian, and owner of the virtual coaching practice, Nourishing Minds Nutrition, where we work together to restore your fertility. Today, I am so fired up about today's conversation because this is a topic I am incredibly passionate about. And what we're going to be talking about today, I'm pulling up my notes here. Hi, hello, by the way, if you're watching this on YouTube. The reason why we have had a delay in podcasts being released in October is because we are officially, and you know this if you were on my email list, which you should be on if you're not already, but we are officially kind of switching up the podcast in two different ways. Number one, we're going to have 2 podcasts a month instead of 4 weekly episodes. And the goal with that is really to get a lot more into the nitty gritty, a lot more into the research, the evidence, and a lot more of the education. It's my desire and goal to use this podcast to benefit you as much as possible, to give you as much information as possible, to empower you to take action in your lives. And with weekly episodes, it was just so hard for me to really get into like the specifics and again, the nitty gritty. So that's partly why we're going down to 2 episodes a month. The other reason is we are officially trying to get on YouTube. I'm not trying, I'm doing it. It's way harder than I thought it would be though, to record and to get used to like talking to a camera instead of just talking into a mic each week. So a little bit more tech and preparation that goes into the episodes now, and all for like the best of reasons. I don't know about you, but I'm an audio and visual learner. So when I can both watch something but also hear it, I retain the information so much better. And again, that's one of the many reasons why I want to officially get the podcast on YouTube. So all to say, let's get back to what we're talking about today. We are talking about why it is so common for active women specifically with period loss or unpredictable cycles, why it's so common for them to get misdiagnosed with PCOS. And since I see this over and over and over again in my practice, this is something I feel very confidently in speaking to of the reasons in which this misdiagnosis occurs so rampantly. And if you are someone who you've had a missing period, you've had like maybe it's PCOS diagnosis, or maybe a doctor or a functional medicine provider say to you very confidently, like it's definitely PCOS, but something about it just doesn't fit for you. You're not as confident as the other providers are about what you can truly feel in your body and what you know to be true to your experience. This episode is for you. And honestly, I think in both the conventional and the functional medicine spaces, this is so often overlooked and it needs to stop now, because what happens in these cases is women like you go further and deeper into their HA, which we'll talk about specifically what that is in today's episode if you're not familiar with the term HA or hypothalamic amenorrhea, and it further perpetuates the period loss, all because they're just simply trying to manage their PCOS. So whether you have a missing or regular period, whether or not you even have a PCOS diagnosis, or you're just kind of wondering, is that why my period is missing? Is it that? Is it something else? Whether your management of PCOS is actually driving things worse. And ultimately, like if you just can't get pregnant with a missing and irregular period, this episode is for you. And I think we just should start first with the overlap and the understanding of, have some compassion for both, again, conventional doctors and functional medicine providers for why it can be so incredibly common to misdiagnose this condition. Because in both conditions, you can have a missing or an irregular period. You can have lack of regular ovulation, which is required to get pregnant. That's the main piece that causes the infertility in both PCOS and HA. And in both conditions, you can have multiple follicles on your ovaries, sometimes called cysts, when viewed on ultrasound. So already you can see like, hey, that could be pretty understanding why there can be some pretty dramatic overlap and some understanding of why a misdiagnosis may occur. And what you'll learn in today's episode is what we need to do to prevent that so that people get the correct diagnosis. Because in these cases of period loss and irregular periods from PCOS versus HA, the treatment is so dramatically different. So we need to be so thoughtful about what we're truly diagnosing people with. I'm about to get into like the specifics of how to get diagnosed with PCOS, but one thing I just want to go ahead and mention, because this often is part of why I think PCOS diagnosis is more common for clients with irregular periods in particular, is with hypothalamic amenorrhea, to be technically diagnosed with this condition, you need to have a missing period for 3 or more months. But what we see in our practice more often actually is irregular periods. So the level of hypothalamic dysfunction hasn't led yet to an entirely missing period, or you've actually already done the work to regain 1, 2, maybe 3 cycles, but your cycle is still wildly unpredictable and still very irregular. So those people still though can have the root cause that's similar to someone who's had a missing period for 10 plus years. So let's officially dig in. So first, let's begin with how do you get a diagnosis of PCOS? To be diagnosed with PCOS, you need to meet 2 of the 3 Rotterdam criteria. And the great news about some of the most recent updates to the Rotterdam criteria, if doctors are using these most recent updates, is it now includes the exclusion of other causes of missing periods, including elevated prolactin caused from a benign pituitary tumor, as well as hypothalamic amenorrhea. So your doctor theoretically should be excluding hypothalamic amenorrhea first, but because of what I just mentioned a second ago with it not always presenting as missing periods, also because lab work can often present as normal, including estrogen, LH, and FSH, and especially because many women who have HA actually are a normal weight and a normal BMI, it's so often overlooked. So I'm so grateful that they've updated the Rotterdam criteria to include this exclusion. However, I still see it rampantly not used. And if we're looking at the Rotterdam criteria, there's 3 things that you need to meet, specifically 2 of the 3 in order to be diagnosed with PCOS, but there's 3 criteria. Either biochemical or clinical elevated androgens, meaning you either have elevated total testosterone, free testosterone, DHEAS can also be used, or you have signs and symptoms within your body of elevated androgens. We're talking about hair growth in areas that are particularly male dominant, for example, like chin hair growth called hirsutism. It may also mean that you're having signs like acne that would be, typical of elevated androgens, or having weight gain very specifically in your abdomen area. So that's the hyperandrogenism piece. The second piece to being diagnosed using the Rotterdam criteria with PCOS is either a missing or entirely irregular period. You would need to have your periods more than 35 days apart or no more than 8 periods a year to meet that criteria of the diagnosis. And finally, polycystic ovarian morphology, meaning that you have many follicles, again, sometimes called cysts, on your ovaries when viewed on ultrasound. But here's the kicker. You can have that with HA too because you are not ovulating. HA can present with either no follicles at all or can present with many follicles. And this is like the conundrum of many with HA. But if we can kind of separate and get a little bit more distinct with that, PCOS will present a bit differently even if there's follicles on your ovaries with HA. Specifically, there should be 20 or more follicles per ovary on either ovary with PCOS, or an ovarian volume greater than 10 centimeters. And it may also have that pearl-like presentation that's so typical to PCOS. In the cases of HA, while I just have mentioned and referenced multiple times already that you can have cysts on your ovaries too, it likely won't be that amount of volume, that amount, it won't be 20 on each ovary, and it should not theoretically have that pearl-like presentation. But again, I can't tell you how often I see women who have absolutely no signs of elevated androgens, which you don't technically have to meet the diagnosis of PCOS, but it is obviously very common. But because they have an irregular period, because they have a few follicles on their ovaries when viewed on ultrasound, boom, bam, they're slapped with a PCOS diagnosis and told to diet harder, work out harder, maybe given medications that would perpetuate HA, even worse, like metformin. And it really makes this cycle so much worse. So with the Rotterdam criteria, if they're using the recent updates, that should help prevent some of this misdiagnosis from happening. And that's something, as you being your own advocate here, you can really ask the doctor for moving forward, being very specific of like, hey, I know what this Rotterdam criteria is. Can you make sure I truly meet this criteria and that you've also ensure that you have excluded, HA. I also want to reference with the Rotterdam criteria, AMH has recently been included, and I do think that's great in most cases. AMH, or anti-Müllerian hormone, is your ovarian reserve matched to your age-related peers. And with PCOS, we most commonly see very elevated AMH levels. But in the case of HA, you can actually have very, very low AMH and very, very high AMH, depending on what your follicles are presenting like when viewed on ultrasound. And that's because AMH is is created by the antral follicles in your ovary. So again, with HA, we can't really use AMH as the clear distinction between the two conditions because you can have low and high AMH, and in both cases, either low or high AMH. With HA, as we resolve and fix the HA, that should resolve itself and get back to a healthy AMH level. So overall, I think you can see here why it's so easy, so clearly easy. Again, I have a lot of compassion for both conventional doctors and functional medicine providers for why it's so easy to get this diagnosis, to get it mixed or to not fully understand the differences between the two. And this is why, in my opinion, we need comprehensive lab work, but also an in-depth assessment. And that's probably the more critical piece that's often overlooked, is really asking a lot of detailed questions to more clearly distinguish the difference between HA versus PCOS, especially not only in, misdiagnosis of PCOS, but especially in cases of lean PCOS, where it's even more common to be misdiagnosed. And again, while you can have a missing period and irregular period caused from the chronic energy deficiency in your body, HA, you can have that at any body size. We most often actually work with women at normal weights and normal BMIs. It is why you don't want to think to yourself hey, I can only have HA if I'm critically underweight. That is just simply not true. So as we're talking about the differences between PCOS and HA, before we talk actually about more comprehensive blood labs, so it's just what I have written down to discuss next, I think we real quickly need to define kind of the different etiology of these two conditions to help you more clearly distinguish them, right? Because you're watching this episode potentially as someone who's been misdiagnosed, you're questioning your diagnosis, you're trying to figure out as you're working to get pregnant, is this HA, is this PCOS? And the etiology of how we get to this place of a missing or irregular period is so vastly different in PCOS versus HA. So let's address that first before we talk about lab work. You've been told you need to gain weight, stop exercising, or do IVF to get pregnant with no period. What if I told you that's not actually true? You're tracking your food, working out, trying everything to be healthy, but your period is still missing. And now, pregnancy, it feels impossible. I know exactly how that feels because I've helped hundreds of women get their period back and get pregnant naturally. Inside my free training, I'm walking you through the exact 5-step method that's helped women like Lex, Lauren, and Stephanie restore their fertility in 90 days or less without extreme weight gain or giving up on movement. You'll learn what's really causing your missing period, why food freedom is essential for fertility, and the customized approach that actually works, even if you've tried everything. If your dream is to see 2 pink lines and hold a baby in your arms, this training, it's your first step. Click the link in the show notes to watch the free training. It's time to restore your period, your fertility, and your hope. Now let's get back to today's episode. So I have this wonderful graphic pulled up that I'm looking at right now. I recently took a course from the Women's Health and Nutrition Academy. If you're a clinician watching this, I couldn't recommend their courses enough. Like I mentioned earlier, I'm a visual person. I really love seeing visuals. So if I can find a way to put this graphic up on this YouTube video, I will. But it does such a great job of representing the vicious cycle, which is what Aya Barmer in the course really addresses, of what causes the cycle of perpetuation of PCOS, specifically between hyperinsulinemia and hyperandrogenemia. So specifically, insulin resistance, which is in almost all cases with PCOS what's driving the condition, causes the state of hyperinsulinemia in the body. This state of hyperinsulinemia causes the pituitary gland to release excess luteinizing hormone, or LH, which then affects the theca cells in the ovary to release excess androgens and indirectly affects the liver in reducing the amount of sex hormone binding globulin produced. And all of this creates a situation in the body of hyperandrogenemia. And this causes an increase in visceral adipose tissue, which then in turn increases free fatty acid production, creating again that vicious cycle, even more so driving the hyperinsulinemia, which causes a hyperandrogenemia, and the vicious cycle continues, which you can see here on this graphic. In contrast, in complete contrast, hypothalamic amenorrhea, or even if we're going to include hypothalamic dysfunction, meaning you have anovulatory bleeds, you have long periods, you have short light periods, is caused from chronic energy deficiency, meaning your body is not getting enough calories, rest, and overall nourishment to support basic physiological functions in the body, let alone fertility. Like your body perceives that you're in such a state of unsafety that it reduces the frequency and the intensity starting in your hypothalamus of a hormone called gonadotropin releasing hormone, or GnRH. Without proper GnRH signaling, this causes the amount of follicle stimulating hormone and luteinizing hormone from the pituitary gland to drop, which means that follicles don't mature properly. And since estrogen is produced primarily in our follicles and our ovaries, we don't have enough proper estrogen production, which then in turn ceases ovulation because we don't have sufficient estrogen nor sufficient FSH or LH. And because there is no ovulation, there is then no increase in progesterone. So there is just dramatically low levels of all hormones: estrogen, FSH, LH, and progesterone. And with lab work specifically, let's get into that, because you can again see like, gosh, that's just so different reasons why the body is essentially not ovulating and not cycling and therefore having infertility. But the reason that the root of these are happening are so dramatically different that of course the treatment for both needs to be so dramatically different. And part of that treatment, in my opinion, always needs to start first and foremost with a true root cause investigation. So let's dig into that component of this. So we talked about the Rotterdam criteria, right? But in my opinion, we need to be ordering really comprehensive blood labs. This is something we order for all of our clients. We order our own blood work because it's, to be frank, very hard to get enough and to get sufficient amounts of the hormones that we want to see to clearly distinguish between PCOS and HA. Because if we ever have a client come to us that actually does have missing periods from PCOS, we want to address that in the specific matter in which it needs to be addressed through blood sugar regulation, addressing the insulin resistance, the likely inflammation, where again, HA is just such a different kind of like path forward as to what we would do to get the missing or regular period dealt with. So for us, again, we order labs because it's rare to get all of this from a doctor. But if you can get this all from a doctor, what you want to be ordering is total testosterone, free testosterone, estrogen, LH, FSH, DHEAS, AMH if you can get it, and then S6 hormone binding globulin. And typically PCOS is going to present with normal to high normal of both free testosterone and total testosterone, normal to high estrogen. That really helps with distinguishing HA. High LH compared to FSH. We're going to come back to that one here in a second, but usually with PCOS cases, it will be a 2-to-1 to 3-to-1 ratio. High DHEAS, high AMH, like very, very high, and then low sex hormone binding globulin. Where in contrast, with HA, what we typically see is low to normal estrogen, low to normal FSH and LH, low free and total testosterone, and either low or high AMH because of what we talked about earlier with how if you have many follicles on your ovaries with HA, you could also have elevated AMH levels. With HA, it often gets missed too because the levels can be normal. Like if your estrogen is 50 or 60, your doctor may say, hey, that's a normal, technically speaking, but that's still on the lower end. Same goes for FSH and LH. If it's right at, an 8, 9, or 10, they might say, hey, that's normal. But for us, we know if we combine that with our in-depth assessment with eating and exercise, and we identify there's some clear issues there, we know that we're dealing with an HA case. Okay, so when we're looking at lab work, I mentioned just a second ago, LH to FSH ratio. So PCOS will typically present with an elevated LH, especially in comparison to FSH. But here's the kicker. Your LH, luteinizing hormone, can temporarily overshoot production as your hypothalamus begins to essentially wake back up. This is pretty common in recovery and doesn't necessarily indicate true PCOS. So if we see that in lab work, which I'll be totally honest with you, can be pretty common to see, we typically want to reorder again as we get the cycle more and more regulated. And if we see consistent patterns of a high LH to FSH ratio, that indicates to us a true PCOS case or an even more rare case, but this can happen. And again, it's why root cause investigation work is so important. You can actually have HA and PCOS. And these can sometimes be the cases where the LH to FSH ratio remains elevated consistently. So if that does happen, by the way, what we always do in those instances is to treat the HA first. We always start with renourishment, getting the body in a state of safety, regulating your nervous system, giving your body the rest required. And throughout that, we would always be supporting blood sugar. We do that with any cases because blood sugar dysregulation can affect egg quality. So in our practice, we're just always considering, anything that could affect egg quality, we want to support that as we are doing the work to get your period back. So in those cases of an HA versus PCOS or a combination of both, we would be doing that from the get-go, as we do in almost all cases anyways. And then as the HA is addressed, we would get into much more detailed work with the PCOS, determining the root cause of PCOS, because that's a different conversation for a different day, more specific narrowed supplementation for that, potentially medication if we think that would be warranted, to work with our doctor to get that, looking at, again, inflammation and deeper blood sugar regulation work too. Okay. So I mentioned as we were doing kind of like an in-depth assessment, you always need to be looking at eating and exercise. And whether you're a clinician or a client watching this and you are either working with a doctor, a functional medicine provider, you're considering working with our team, or you're just simply like going about this trying to figure out what the heck is going on, you always want to combine looking at the Rotterdam criteria, the comprehensive blood labs, not just simply, testosterone and estrogen and calling that a day, enough. You always have to take into account your history with dieting and disordered eating, your current eating and exercise patterns, and your stress load and nervous system regulation. When it comes to nervous system, we always address this through an HTMA or a hair tissue mineral analysis that helps us clearly see like the state of stress that the body is under. And while we don't use that to diagnose HA versus PCOS, we do use that in the picture of, okay, what is going on in that person's body and how do we support them to restore their fertility and get pregnant? And I say that specifically because with both PCOS and HA, you can have a dysregulated nervous system. But specifically, eating and exercise will really clearly help us see HA versus PCOS. People with HA are going to have really low carb, high protein, very strict diets. Are the people who rigidly, put their food on MyFitnessPal every day. They count their almonds, they weigh themselves daily. And certainly many people with PCOS have disordered eating. There's actually statistics that show that you can have 4 times higher likelihood of disordered eating with PCOS, which again kind of adds the complexity here and why I just so personally believe deeply in working with a period recovery specialist. But all to say, typically with an HA case versus PCOS, you're just going to see a lot more stricter diet and exercise patterns, a lot of intense exercise specifically, and a lot of lack of rest days. Typically, these are going to be people who are exercising 5, 6, 7 days a week, as well as walking 10, 20, 30,000 steps per day. They're going to be the more type A, perfectionistic, highly overachieving. There's just like some common characteristics that come alongside HA, and that really speaks to the stress load and nervous system piece too. Okay, so if we are like my clients, Allison, Caitlin, Sarah, Lauren, who all came to me with a diagnosis of PCOS. They got it in their teens, actually, when they had eating disorders, and were put on birth control for over a decade, and then came off birth control to try to get pregnant, and boom, their periods went missing, and they've been sit down this, and crazy roller coaster ride of trying to figure out what's truly going on here, PCOS versus HA. If you are like my clients, here's what I want you to do. The solution is not just to assume you have PCOS simply because you have a missing or an irregular period. You want to start with a comprehensive root cause investigation. You want to have a personalized protocol based off your root cause investigation, what your blood labs show us, as well as your HMA testing and your full health history, including current eating and exercise patterns. And we really need to make sure that you're getting support every step of the way so that we can address, really in the cases of HA, the root of why that's happening is your relationship, your strange relationship with food and exercise. So we have to address that as we're following the customized protocol to get your period back and get pregnant. If you at the end of watching this are like, this has piqued my interest. I think there is a high likelihood here that I could have a misdiagnosis or an unsure diagnosis, or I'm personally trying to figure out what the hell is going on in my body. Let's figure that out together. Like, that is so much of a heavy burden to bear on your shoulders, and having an expert to guide you who understands just so deeply why active women so commonly get misdiagnosed with PCOS and help you truly see what's going on in your body, because we need to understand your body's unique reason why it has a missing or irregular period so that you can get pregnant. we would love to work with you. This time of the year is very busy for our practice. We have very limited spots left inside Premier Period Recovery for fertility, but if you reach out today, we may be able to get you in by the end of this year so that you can get pregnant in 2026. If you have any questions, drop them below in the YouTube comment section. So glad to be officially on YouTube and cannot wait to be back in 2 weeks for another episode. Until next time, know that a nourished body is a powerful one.